You're tuned into the Zealous Podcast. I'm your host, Rocky Snyder. This week I've got Dr. Will Workman on the show with me. He is the team doctor for the Oakland A's. Spring training is just about over, but he's down in Arizona helping with the crew that's down there, and eventually he'll make his way back up to Walnut Creek, California, where his practice is, and continue to work with the players. Now, meanwhile, before we get started, I want to let you know Setanta College is the place to go for a Master's of Science degree in performance coaching, as well as sports injuries and return to performance management. They've got degrees in applied sports biomechanics and movement science, as well as applied sport and exercise psychology. So you can go to setantacollege.com. It's mainly online learning with some in-person learning as well. If you enter the code RS10, RS10, get 10% off tuition today. So check them out at setantacollege.com. Follow us on Instagram at Rocky_Snyder, SNYDER. Hit that subscribe button, tell a few friends, and enjoy the show. Well, Will, thanks for coming on. I really appreciate your time. This is kind of unique because it's not very often that we get deep into the medical side of professional sports. I'll talk to athletic trainers, physical therapists, but to actually have an orthopedist on, team doctor, and so on is a treat. And well, first, welcome to Zealous.
Well, thank you. It's an honor, a pleasure to be here.
Well, it is great. And it's an honor for me because when I look at your resume, not only are you with the Oakland A's and you've been with them for a little while, but previous to that, you're with the New England Patriots, which is my home team growing up outside of Boston, and went to the University of Massachusetts back there. You may not know that. And also you worked with the Boston Bruins. And you went to Harvard Medical, which is amazing because prior to that, you went to Yale. So I definitely want to discuss when it comes to the crew and rowing on the Charles. Are you favoring Yale or Harvard? Or when it comes to the football season, who do you root for? First of all, is it Yale or Harvard?
It's got to be Yale. I spent a lot more time. My entire residency for 5 years was at Yale. In fact, when I was with the Patriots for the year during my fellowship, I asked my mentor if I could skip one of the road trips. I believe it was to Miami, so that I could go to the game down at the Yale Bowl and be on the sidelines for that instead. So I definitely, I like the Ivy League a lot. I like that sort of sensibility, at least that old school.
He let you go once you knew it was you were rooting for Yale. He still said okay.
He did, yeah. I guess he was a good guy that way.
Damn, Connecticut Yankee. That's what you are, basically, but that's all right. But tell me, after finishing up at Yale, going to Harvard Medical, and at the same time getting in with the Patriots, what was that like? Was that the direction you were thinking of going in terms of sports med?
Well, in terms of covering a football team or just yeah. So it goes way back for me. I mean, my first love, if you will, is in sports was baseball. I was a baseball player, and from the time starting about sophomore year of high school, I decided to become an orthopedic surgeon, believe it or not. So I was a baseball player, and I was in sophomore biology, and said, "This is cool stuff. I like learning about life, and I'm kind of an efficient guy." And I'm like, "Well, how can I combine sports and science?" And sports medicine was sort of a thing that was being thrown around. This was probably early 80s. And orthopedic surgery, I thought, would be a way for me to be able to do everything, or at least not, once I was trained to be a surgeon, I could do that and other things. And so everything kind of flowed from there.
So you didn't necessarily have a throwing injury, rotator cuff, elbow, or anything else that made you go see an orthopedist, and then that inspired you? It was actually in a biology class?
Yeah, in fact, I tease. Well, I don't tease. I tease myself when I tell my players. I was a left-handed pitcher, and I tell the players I never had a Tommy John injury because I didn't throw hard enough. You need to throw hard in order to get a Tommy John.
But you played in the majors, or at least you made it into an organization, correct?
Yeah, in the minors. I was drafted. I was actually drafted twice out of Berkeley, drafted by the Tigers, and then I turned that down because I was in the middle of applying to medical school. And then I signed with I got into medical school the next fall, and then I signed with the Angels in '89.
Wait, so you were in medical school and with the Angels at the same time?
No, I was still at Cal. I was a pre-med, at
Okay.
Berkeley, and I got into medical school. And once I signed with the Angels, Tulane Medical School, where I went for my medical school portion, the dean allowed me to defer my admission for a year. So I signed and I played almost 2 seasons, and then I basically quit when my deferment came up and went to medical school. So I was kind of, I went into college. I was barely recruited, not very good student. Went into Cal, but with my sort of ambition and ego, I said I'm gonna sign with a pro team, and I'm gonna get into medical school by the time I'm out of here. And I happened to do that. And then once it came down to, I mean, it was hard enough being an undergrad, being pre-med and a Division I baseball player, but by the time you get to pro, like I had to choose. I said, I'm going to either go all in medical school or all in baseball. So I left baseball and went to medical school.
What was that? If you could think about that defining moment, because I'm kind of curious about that, how we choose paths, then we hopefully don't regret the path not taken. But what was that like?
You know, that's a great question, and I can answer it from my 24-year-old self, and I can answer it from my 57-year-old self, because I think, you know, upon reflection, I things went into it that were not quite on the surface. But at 24, I was in the minor leagues, and I, you know, it would have been a few more years till I got to the big leagues. And I think really what it boiled down to, and this may sound weird or not, I don't know, but I felt like if I made it in baseball, really what my life and my career boiled down to was being an entertainer. And in medical school, it was my calling. And you don't know quite it's your calling until you actually get there. But I can say at 57, it was definitely my calling. And I think also just the amount of time that it takes to train, to go to medical school and to train to be an orthopedic surgeon, I was looking at 10 more years after I quit baseball until I could work, basically. And, you know, if I quit baseball at 34 instead of 24, that would have been 10 more years, you know, instead of going to a 2-year graduate school. So I think that sort of looming in the distance kind of helped push me out.
And was there potential? Was there room that there was opportunity knocking for the majors, or were you just developing yourself in the minors, and it would have been amazing had you gotten called up to the big show? But you know, the percentage of guys in the minors getting called up is not that huge. So where were you in the scheme of things, minus your ego?
Yeah. Well, and then it's another great question. I think I actually got a letter of recommendation from Dr. Job for medical school, and because I was trying to get his advice about whether to stick it out. And you know, I was definitely not a top prospect, but I've made a lot of things in my life work through hard work. And you know, I was a left-handed pitcher, and I think had I stayed with it, I would have made it to the majors. I don't have any doubt about that. But it wasn't. They weren't losing a big prospect by me leaving, but it was just one of those things where. And the other thing about baseball too is that I loved baseball when I was a player. When I got to play, I was an outfielder in high school, and I had a really high batting average, and that I loved to get my uniform dirty. I loved to be in the field every day. And when they took the bat out of my hands and I became a pitcher in college, it just wasn't the same game to me. I tell people now, if I was playing outfield in the minor leaguers, they would have had to rip the jersey off me to make me leave. I would have stayed in it forever. But for pitching, it's like I could leave that.
And what was your best pitch? Just got a side note.
Well, probably a strike, but I had a good curveball, and I developed a really good split finger fastball actually when I was in my second year in high A ball. That was a good pitch. I had it sort of I had two split fingers. I had one when I was behind in the count where I didn't spread my fingers too wide and I could get it over the plate. And, you know, just it looked like a fastball because you can't really put that much pressure on the ball with your fingers split. And then I had a really wide split for when I was head in the count that would just dive in the dirt. Good pitch.
And then so you leave Berkeley, Tulane, you make your way Yale, Harvard Medical, and you don't land in Fenway Park. You land at Gillette Stadium. What the fire is that all about?
Yeah, well, it's just opportunities. I think I always had an affinity for the Ivy League, like I said, and I think I would have gone had I had the opportunity. Not that they were knocking at my door, but maybe thought about that for college. Although for a baseball player, to be honest, the Ivy League's not the place to be. I remember pitching against Cornell. They came out to Berkeley in February, and they looked like freshly shorn sheep. You know, they hadn't seen light of day, and I had a very enjoyable outing against them. It was like lambs to the slaughter. You know, they were blinking in the bright sunlight, and you know, they just don't get the weather. I mean, you're from there, you get it.
Oh, I know.
But I always really liked the Ivy League. I like the fact that, you know, those are true student athletes. You know, in a way that I've always clearly I viewed myself. And so when I had an opportunity to be a part of the Ivy League, I took the residency at Yale, and then the Harvard thing. Yeah, the opportunity to work with very closely with multiple sports teams. Even though it wasn't baseball, there was a different thing covering baseball. But I figured I kind of knew baseball already, and I think I did get the fellowship in part because I had been a professional athlete, and when you're dealing with professional athletes, just having that sort of sense and feel around the locker room is really, really helpful.
And not only you're with the Pats, you were with the Revolution, so basically same office right there at Gillette Stadium. Yes. And you spent some time in Boston. What drew you back west to the A's?
Well, that's another good question. My wife and I became very fond of New England. You know, we're both Southern California kids. I grew up in Santa Barbara, and my wife in San Diego. But you know, we were very fond of Connecticut in particular. I think the one year I was in Boston, that it was a little frenetic for me. It was a busy big city compared to sort of the pastoral setting of Connecticut, if you will, sort of outside the city, and you know, places to surf there, places to hunt. We actually got into hunting a little bit and hiking and all that. It just was a little mellower. Friends I was going to go into practice with, but ultimately the opportunities weren't there, and I felt more comfortable coming sort of back to my roots. And the Bay Area kind of became my sort of compromise between my Southern California roots and the East Coast, if you will. There's kind of a East Coast sensibility to the Bay Area that I enjoy without the very gray marches.
Yeah, no, I completely can relate to that. You don't have the glitz and glamour and shall we say plasticity of Southern California up in the Bay Area. There's definitely a nice connection between Boston and San Francisco. Now, I have to say, you snuck it in there, so we got to talk about it. You said surf, and so you surfed back east. How long have you been surfing?
So not as long as you'd think, and you know, growing up in Santa Barbara, I lived 3 miles from Henry's Beach, and I could ride my bike there. And
nice.
I did mostly boogie boarding, but in the 70s, and where you live in Santa Cruz reminds me a lot of my hometown where I grew up. The way it was. I mean, Santa Cruz is changing too, but you know, I rode my motocross bike carrying my boogie board down to Henry's Beach, and you know, 9, 10, 11 years old. I started surfing just a tiny bit, but my dad was both a teacher and a football and baseball coach at the high school. And during the 70s, there were surfers and there were athletes, and my dad knew what the surfers were doing. And so, I always loved the ocean, loved the water, but honestly, I didn't really start surfing until I was in my early 40s.
Early 40s. Oh, all right. Yeah. Not bad. Yeah. So what were
something I never thought I was going to do.
That's great though. Where did you surf back east?
Well, so I have a good buddies that grew up in Connecticut that took me. So we would go to Narragansett. We would surf in the Cape. And it was only 3 times I did it there. And it was that same group. When I was 41, we took the family to Costa Rica to Nosara for a family vacation at Playa Guiones. And that was, I look back on kind of my boot camp. I surfed twice a day for 10 days. And I was like, you know, lifelong dream. I'm finally going to surf. And it is by far the hardest sport I've ever done. And I've done a lot of it.
All right. Well, we could, like I said, we could talk. We'll bring it back in the mix because we got a lot in common. We're both left-handed. We're both goofy foot surfers, and we both have some prime spots on the West Coast. But back into baseball, I would really want to get your take on it. So, you're orthopedist, but you say you're more traditional, like old school in regards. I know. Just from some of the stuff that I've read about you, you're not scalpel happy. You want to find other ways potentially before going under the knife. But when you say you're more traditional, what does that mean when you're talking about sports med doctors?
Yeah, well, yeah. So you're an orthopedic surgeon first. I mean, we spend the bulk of our training in the 5 years, 6 years sometimes, in all of the different disciplines in orthopedic surgery, whether it's joint replacement or trauma or pediatric orthopedics or tumor, and then our specialty training, our sports medicine fellowship is usually a year on top of that. I mean, you're already a fully trained surgeon, but there's a lot of skills you learn. And I think, generally people think of, or at least in our field, we think of sports medicine surgeons as arthroscopists, as guys that are, doing arthroscopy surgery, shoulder, and typically shoulder and knee is a common combo, although hip has really made a lot of advances. And so guys are getting a lot more hip training than they used to. But I think sports medicine surgeons are considered, arthroscopy surgeons. So that's one specialty. And then there's guys that just do joints, they'll just do total knees, total hips. And then there's guys that just do trauma. And then there's guys that sort of general, but general are guys that kind of do kind of basic, arthroscopy stuff, not complicated, maybe basic joint stuff, not complicated. And I guess, for somebody that has specialty training, for somebody that's taking care of a professional baseball team, I still do total joints and, I do total hips and knees, and on top of, Tommy John surgery and ACLs and rotator cuffs and everything else. But I definitely, and to me also, being a team doctor, I'm not going to just see an elbow. I'm going to see a hip, I'm going to see a hammy. You need to be able to look at the athlete holistically, at least holistically from my little piece of the team. As the team physician, I need to be able to, kind of understand a lot about a lot of different things. And so I think my practice fits well with being a team physician that way.
So out of the interdisciplinary team that makes up the medical and training staff, who would you say you learn the most from?
Oh, all of them. I think, this is my 14th year, 15th year, maybe the team, and it's evolved. It's a little bit different organization than we started, but I'm now the head team physician, which I'm proud of. Put me in that spot last year, but our athletic trainers, I mean, their skill set, I go to them when I have an injury, and our strength and conditioning coaches, the innovation and the thought and the sophistication that they have, and the work that they put in to every single protocol and different, being creative about different injuries coming back from, it's endless. And I don't have a lot of time. Like spring training is a time when I can spend a little bit of time around them. During games, during the season, there's not as much time for them to sort of sit back, but I constantly learning from them. And baseball is the kind of sport too, where it's, we have a lot of time. It's not like football, we're on the sidelines and it's like, go. So we can sit back and chat a little bit, and it's good that way.
So are you at all the home games? Do you travel to the away games as well?
So the way Major League Baseball is set up is we cover the visiting team when they're in town, because if we didn't have that, it's very difficult. I have my own practice and then I have the team on top of it. So I'm responsible for all of the home games, but I also have other surgeons that I divided up. One of my colleagues, Mike Freehill at Stanford, is orthopedic surgeon, also an ex-baseball player. We divide the home games in half. So I'm at about half the home games, maybe a little bit more. So about 40 games, still a lot.
And then your own private practice.
Yeah.
How many hours are you 3 days a week? I mean, how often are you either in the surgical center or in your office?
Yeah, all of the hours. Oh. So yeah, my typical week, I mean, my typical week would be Monday and Tuesday. I see about 40 patients in the office each day. So 40 patients Monday, 40 patients Tuesday. Wednesday, I operate all day. Thursday, I'm either seeing 40 patients in the office or I'm doing surgery at the hospital. And then Friday, I operate. So I'm seeing anywhere
40 patients? Are you seeing them in a group setting, or are we talking like 15 minutes at a time for 10 hours?
Yeah.
No way.
Mm-hmm.
15-minute slots for 10 hours.
Yeah, it's grindy. And of course, my office isn't like, I'm not doing treatments in the office like you're doing treatments, where you set time. It could be a new patient, it could be a follow-up after surgery. So and I have a great, I'm still, and that's the other thing about my practice being traditional. I'm a solo guy and there's not many of those left. So I have great office staff. You call the office, somebody answers the phone, they know how to manage the schedule, and patients, they call people back. So, we do our best to really kind of, make the patients feel like they're getting cared for.
And what's your max? Is this because of the insurance game? Is this your own personal preference or professional preference? Like, I want to jam in as many people as I can see in 2 days, or what?
No, I think it's demand, honestly.
Really?
When somebody gets hurt, a friend gets hurt, and you're like, I want to get him in to see Dr. X. He's like, well, he's so busy, it's down the road. Well, you try to accommodate, and I could probably see less. I think it is difficult. Again, I have the other part about my practice is, you alluded to it earlier, and I like to do what's appropriate for patients. So I'm not a surgeon where I have 40 surgical patients. I'm seeing people that come in with musculoskeletal problem, and a lot of those aren't. So, keeping that balance, keeping the surgery schedule full, if you will, requires me to see a lot of patients. But it's just, I think I think that's about the right numbers so that it's not being too crammed. Most of the time, the patients don't ever leave the room without, having all their questions answered. And, sometimes they're trying to leave before I'm done talking to them. But yeah, no, it's just, I think it has to be that way. It's hard work. And, when it comes down to cutting people open and taking their lives into your hands, you want to have a lot of reps at it, not just, in the OR, but dealing with them outside. And doing it sort of half-time or part-time, I don't think will ever work for me, to be honest.
And the majority of your patient load, are these of the athletic population, whether recreational, amateur, professional, or are these people that are just structurally degraded because of sedentary lifestyles, or is it a combination of everything?
It's a combination, and you'd crack up if you saw my office walls, because one of my favorites, I just got a picture from one of my patients. She's 85, and I think I've done reverse total shoulders on both of her shoulders, and maybe both her knee replacements. She's got a picture. I have a picture of like, Matt Chapman and Dalton, these professionals that I got my 85-year-old mixing with a mixing bowl. She's got her cooking apron on,
That's great.
Yeah, I got all kinds of, just it's everything. And it's not so much, I certainly don't subscribe to the cliche that everybody's an athlete, but one way or another, people are trying to be active, and everybody's activity level is different, and some people are just gifted with the ability to have the willpower to do things, or have the athletic ability to do things, and others don't. But yeah, it's one of the nice things about orthopedic surgery is people are trying to get more active. They're in your office hurt, and they can't do as much as they could, whether it's just going for a walk around the block with their dog, or running an ultra marathon, or playing professional baseball. And I'm sure you see that too with what you do. But it's cool that way. And I think if my practice was with all athletes, or was just kids, or just old people, or I don't like that monotony.
Oh, I hear you. No, I can see variety, novelty. The brain needs it, definitely. Now, it's curious, Will, because we had ourselves a sports med doctor in Santa Cruz that I highly referred over. He was he was a character. Cowboy boots and a Hawaiian button-down shirt was how he showed up for work, and he was not willing to go headfirst into surgery. It wasn't his answer and solution, and he retired not too long ago. And I have been hard pressed to find somebody of that caliber. And what I mean by that is somebody who is sports medicine first before their orthopedic surgeon, if you know what I mean. It seems like there can be a delineation between these two. And it seems like, and maybe it's just me, but maybe you'll help straighten me out here, that there is this propensity for a higher level of a popularity of orthopedic surgeons, where we're just going to go in there and look. I saw the X-rays, I saw the MRIs. You're going to need to get this snipped. We're going to need to do a partial or total replacement here. We're just going to go for it, rather than the approach that the sports medicine doctor said, hey, you know what, let's see what these movements can do. Maybe we'll do a little bit of cortisone, maybe we'll do a little muscle stim or whatever. We'll try and get this going. I don't really want to go the route of surgery unless we have to.
Yeah. I mean, I like to think what I do for patients is the appropriate thing. You know, sometimes surgery is the appropriate thing. You know, sometimes not doing surgery is inappropriate. But yeah, to your point, I mean, I know I personally am looking for anything other than surgery, but to get myself better. And you know, I still do a lot of, you know, we didn't touch on it, but I've done several Ironman triathlons. I just did one. I did Leadville Trail. I had a bad crash a couple of years ago in the Leadville. Oh. My shoulder's still kind of jacked up from it, and you know, I'm having Brian Schulman, you know, make sure that it still works and not. I know I could probably have probably a posterior stabilization, but I also know that I'm willing to put in the work to keep it stable, and that's a really key thing. And you know, some patients, you know, they're looking for a quick fix. They're looking for the pill. They're looking for the surgery, and you kind of have to talk them off that ledge and like, look, you know, if you went about it a different way, but not everybody's built that way. It's hard, and you present all the options. And I think too, like you mentioned, sort of arthritic things. You know, I try to present it in like, these are things that can help. You have to look at what the likelihood of it helping and the longevity with which it will help. Like if it's something, are you willing to, you know, undergo pretty rigorous PT strengthening, you know, movement changes in order to get back in line? Or do you want to get a shot every 6 months? Which, you know, if you do, you can go somewhere else because I don't like doing that. Or, you know, or they'll come in and say, I just want my knee replaced. Well, I mean, it's not that simple. I mean, it's a big procedure. There's drawbacks to it. You know, maybe getting to your more appropriate weight would be a good start, and you know, some supplements that can work, and different ways to move and different types of exercise. But those are the challenges I think, you know, both you and I face with some people, is getting them. I don't think, you know, athletes understand their bodies that have used them for a living, but people that didn't use their bodies for a living, I think, have a harder time understanding, you know, what movement can do.
No, agreed. I find that myself. Okay, you mentioned pressure in your realm, in your experience, and by the way, the triathlons, hats off to you. I did a mini once, and I said, okay, check that off my bucket list. I don't have to do Ironman like you freaks of nature. I don't know. There's something not quite right upstairs. I don't know if you've been told that or not, but
yeah.
But
starting with my parents are the first ones to tell me that, but yeah. And I think, you know, and I only mentioned I did it just because it obviously it makes it easy to understand that, you know, I'm moving my body. I don't do them well. You know, I think with endurance sports, I think Eddie Merckx said, you know, the only thing about endurance sports is it doesn't get any easier. You just go faster. Well, in my case, it doesn't get any easier, and I'm not going any faster either. It's very grueling, but it's also epic. You know, it's my buddies and I like to call it's a man day when you get out there and, you know, get through that. But it keeps you in touch with that stuff. So it's I don't do them all the time. It's just occasionally, but
you got anyone lined up right now for the fall?
No. So I did the one in the fall. I've done Escape from Alcatraz a few years in a row. I really like that one. I'm going to do that. And then nice. the Tahoe Trail 100 mountain bike race this summer. But I'm trying to surf more this year. And
right on.
Yeah, all that training for Ironman got me out of my surfing. Maybe some more golf too.
And then the Escape from Alcatraz, wetsuit, no wetsuit?
Wetsuit, definitely.
All right. And let's see. So you are sane to some degree. So don't think that you're completely crazy. Okay. So I was thinking about pressure, and you have been amongst at least 4 professional sports organizations. And do you find that you have pressure upon you to solve the problem as quickly as possible, but there are times that you would prefer to go a different route. Do you know what I'm saying?
I do. And I think I was expecting that when I first came on board. And it might be just the way things were in sports, particularly baseball when I was younger, or maybe it was from my experience dealing with the NFL. I won't name names, but my mentor one time, the former coach for the Patriots, my mentor was coming off the field with a player, and he yelled at him for not getting the guy better, while he was coming off the field. I think there's a lot more pressure. I think there's a lot more pressure in football because it's, there's less games and it's, 1 week at a time. But in baseball anymore, it's the injury list, form of the DL called the IL now. I really don't feel that, honestly. I think if anything, and I've just gotten used to it because it's been over a decade that I've been doing it, but and it might just be our organization, but they're very good about understanding that there's a time frame for guys to get better, and if you mess with that, you're going to have problems. I saw a guy today that he's got a bit of an elbow issue, having a little bit hard time extending it, probably inflamed. We're gonna shut him down for a bit. It's spring training. We have a whole season ahead of us, but I've never felt, fortunately, I've never felt really from upper levels that guy pushing me to get guys back out there, if that's what you're asking.
Yeah.
I feel it from players sometimes, and I really try to position myself with the players. Like, look, I'm just here to try to help you. I know that, technically I'm employed by the team and I'm their doctor, but I'm a doctor first, and I'm here for you. I've been in your shoes before. I understand it. I'm not going to tell you anything that I don't think is in your best interest or something that you want to do.
Well, that's encouraging to hear. Okay, so you are currently in Arizona. Spring training is underway, and your role down there is fill in the blanks. What are you doing down there?
Yeah, so this is actually my fourth trip this year, and this being my 14th year, and I've stayed at the same hotel for 14 years. So this is, if you add it up, I'm like 40 or 50 times at this place. It's I don't own a vacation home, but this might be as close as there comes to it. But so every year the pitchers and catchers report in February. So we come down and do all the preseason physicals, which is basically going over anything that they had going on in the off season. They'd leave the season with injuries, how'd their rehab go, check their bodies. If there's anything else going on, we get more imaging. And then I did that with the big leaguers. I did it also with the minor leaguers, which is a lot of guys. And that's just, getting them screened and out on the field. And then I've been back a couple times. We kind of rotate through the primary care doc and the docs just because we can't be down here full time. So I spent 2 out of the 4 weeks down here covering games and taking care of injuries as they come up. And people might ask, well, baseball, nobody gets hurt in baseball. What do you get, a hangnail or something? But every injury is, and particularly the big league level, is very much magnified, and there's a lot of domino effect. They got to look at guys to replace them on the IL, and moving guys around, and is this guy we really want to keep? And I try to stay out of that part and just focus on what the injuries are and how to get them to the next thing. But let's, for example, today I showed up and saw 2 guys, and that was probably an hour, for 2 kind of little things. It wouldn't have taken an hour if it was in my office with my regular patient. But there's, it's the implications of, they're under a microscope, and if you don't make the right decision, or they go back too early, or they're going to get second opinions. And they usually get second opinions from good guys, and so you have to kind of be on your game to make sure that. And some of these things are very nuanced. The injuries are it's not like a blown ACL, or you don't have a bone broken in 2 in front of you. There can be pretty subtle things. We rely a lot on MRI to kind of help with the clinical stuff, and we take a lot of MRIs and sequential MRIs. That's something I've just kind of got used to doing.
Sequential MRIs, what do you mean by that? Just over the period of time?
Exactly, yeah.
And so I jokingly say that MRIs tell you everything, that you owe 3 years of back taxes, your parents were never married, and so on and so forth. But they reveal so much. So my question, Doc, is like when you look at an MRI, knowing that it's showing tremendous amounts of an athletic body, wear and tear and whatnot, how do you decipher all of that information? How do you get down to the nitty gritty?
Yeah, and I think that is the big difference between my professional patient population and my private patient population. MRI is a really good example of the distinction. That you've probably heard the adage, if you can work on race cars, can work on regular cars. The pro athletes are the race cars, and the stuff is just, they're on the edge physically, particularly like pitchers when they're throwing, they're at their max effort. And so the littlest things can be magnified, littlest things that you would see on MRI that don't really affect the general population. And so, like, probably 9+ times out of 10, a patient that I see in the office, I'm going to know what's on their MRI before I get it. You get the MRI to confirm what you're suspecting. With these athletes, you kind of do, but you're trying to get them from 90% back up to 100%. And so that little stuff you want to track. Like if they have, for example, with this throwing shoulder, they can get these little cysts under the rotator cuff in the bone that you would not even really care about in a general population, but that's from pressure on their shoulder. And if you get one 6 months later and they're bigger, well, their shoulder is kind of taking a nosedive type of thing. The guy I saw today, he's got I can say it without names. I mean, he had a little spur in the back of his elbow a couple of years ago that I looked at and I saw in his MRI that I'd probably blow off in the general population. But it turns out he was a little bit painful there today. So we're going to get an MRI to see if that's changed, because that's going to, he may get surgery for that. We may go in there and clean that out. Or if it hasn't changed, maybe give him a cortisone shot. It's early in the season. We want to get the elbow calmed down, get him ready for the long haul. And of course, how you treat him is dependent on where we are in the season too.
Okay, so you've got a grade or variance of symptoms, orthopedic concerns, and some are not going to be enough that it takes them out of the game. So you're not going to need to create some type of return to performance pathway. But then you've got these other athletes with adductor strain, grade 2 hamstring strain. There's Tommy John surgery that's looming or whatever. And now you've got to create a pathway with your interdisciplinary team. Yeah. I imagine you're obviously in phase 1 where you're diagnosing, creating prognosis and evaluations. How far do you carry into that pathway? Do you know what I'm saying? Like to the point where they're back in the game? Like, are you all the way through that, or do you hand the baton off and just kind of like, hey, let me know if something comes up. I'm out of here. I got somebody else to focus on.
Yeah. So I have a good one for you. I was just thinking that one of our infielders, this is an unusual injury. He had a strain of his iliacus. Okay.
Oh, nice.
Like on MRI, not just sort of like iliopsoas tendonitis, but like his iliacus.
Wait, you could see it on the MRI?
Correct. So when I was examining him, that's an example. Like examining him, it's like, he kind of injured it going lateral for a ground ball. And I'm like, when I examine him, I'm like, this is kind of iliopsoas, I think you're probably a little iliopsoas. And then we got an MRI, it's iliacus. Like, so yeah, definitely iliopsoas, but higher up, right? So that's a muscle strain, just like a hamstring strain. And so we implement a protocol. Now I turn that completely over to the athletic trainers and the strength coaches. Like they develop they tell me what they're going to do. We have injury reports every day. They give me feedback on where the player's at. I monitor them. They see me, depending on what it is, every other day, on a weekly basis, every day, depending, of the acuity, depending on the acuity and where they're at in the process. But they get my feedback to sign off on what they're doing, partly because I'm in the position to, prescribe medication and decide about surgery and things like that, but also just for them to have a check. But in terms of me devising plans for them, that's where like I learned from them, right? I mean, nice. You guys, that's, when I became an orthopedic surgeon thinking I could do everything, you can't do everything. You can't do everything in sports medicine, and it's evolved so much in those fields. And it's fun to watch, but it's very sophisticated.
And then speaking of evolution, sophistication, this team, that in walks the sports scientist now. You know, within the last 5 or 10 years, an emerging career path has occurred. So with the sports scientist on the A's and yourself, what's the interaction there? How do you utilize that insight and information, or vice versa? Is there is there something that you're kind of like, oh, this is kind of cool?
I think it's amazing, to be honest. I mean,
Yeah.
I mean, for me, sports is always, I've been fascinated by the biomechanics of sports, just maybe because I didn't have good form or whatever, but the idea of like beautiful pitching mechanics, or beautiful hitting mechanics, or beautiful surfing mechanics, or, you know, the tennis stroke or whatever. And the sports scientists we have being able to evaluate biomechanics at a level that, you know, we never could when I was playing. And the stuff that I'm learning about mechanics because of the tools we have. And of course, now I'm just sort of a student of it on the sidelines, and I can kind of just be that and not, you know, we have experts in that, but we started a study with the A's on split finger fastball, and you know, I actually had more input based on my background in pitching, because I'm like, you know, we really need to look at this particular muscle group, because, you know, I just remember like split finger, like that, you know, there's going to be a lot of pressure in the forearm. They had something, we were looking at some arm speed parameter, and like, well, it's probably slower because of this and that. So I can kind of give a little bit of input, but their level of understanding is way beyond. And I think it's a brilliant piece. And a lot of the colleges actually now, Berkeley just contacted me because they're going to try and get a pitching lab, you know, with biomechanics in there. I think it's going to be a staple. I don't know how it is with other sports, but I mean, baseball really lends itself to it, particularly for throwing.
Yeah, no, that is so heartwarming on so many levels, because you can probably attest to all the years of medical school. It was more about surgical procedures, techniques, and so on, like you alluded to earlier, but not necessarily connecting articulations and force production together and looking at like kinematic sequencing, kinetic chain reaction through the body. And then you get this biomechanist or the sports scientist saying, well, look at the torsion or the velocity of the hips, and you see how there's not enough, and it's causing that shoulder to really become overpowered, or doesn't generate the force needed, so it's got to be made up somewhere else. I mean, you must be kind of geeking out over that, going, holy cow, now I'm getting a better understanding of why these things keep occurring. Why do I keep finding these occur? Is that true?
Oh, hugely. And I think for me, my geeking out is kind of focusing, and I never want to be a guy that focuses on one area, but the hip and the pelvis for me right now. I mean, I think that is just a source of endless learning and understanding. I mean, it's the true core of the motion, you know, in the kinetic chain. And, you know, little stuff like when I was taught to pitch, unfortunately we got it wrong. I mean, I was taught to keep my front side closed, and I think that screwed up my pitching. And it, you know, you're sort of taught to kind of throw open your hips and arm at the same time, which that's not it. You know, there's that shoulder hip separation, and we can see it very clearly, very quantitatively now with you know, the TrackMan and everything else. And it's fascinating to me, and how, you know, the knee actually bends a little bit before it hits the ground, and the hips, that last acceleration is right before foot strike. Like it's almost like you're punching before you hit the ground, and that's how you're supposed to do it, and you can see that clearly. And it's just little things like that I think are huge. And
huge.
Yeah, and then in that there's an article that I have, and I'm still trying to sort out the diagram, but how, you know, the hip shoulder separation ends up affecting, you know, elbow height, shoulder lag, all this sort of stuff that leads to shoulder problems. So the kinetic chain, big, 100%.
That's awesome. That's so encouraging to hear too.
Well, I did. So back in my residency days, I did, you know, well, I mean, being a beach kid, those triathlons that I mentioned, like I did sprint triathlons, I would run them barefoot. I really got into barefoot running back in the 90s before it was a thing. And I did my whole sort of thesis dissertation when I was at Yale on barefoot running. And I did a biomechanics study on it up at the Children's Hospital in Hartford. You haven't read it because it didn't get published, but I won an award from our sports medicine society for it. But it was, I had force plates, motion analysis cameras, and I took 20 runners. I was very into the biomechanics of stuff, but and that was fascinating. Of course, it's barefoot running is a big thing now, but the amount of force on the knee with running shoes was 37% higher with running shoes than barefoot. Wow. When you switch the impact from the midfoot to your heel, and that was so. Yeah, I mean, I've always liked that stuff. And again, it's so much more sophisticated, and they're way beyond where I am. But it's just they have a whole room in our clubhouse now with television screens and monitoring all this stuff. It's like looking at the Matrix, with all the data they have. They can see a person pitching just by all the numbers on the board.
That's so cool.
Isn't it?
That is that. Yeah, it really is. And so you mentioned research too, and I just I'm scratching my head here, Will, because I'm like, when does this brother have time to actually initiate some type of study? But you're doing research at the same time. You're seeing 40 patients a day, a couple days a week, not to mention doing 400 surgeries a year, going down to Arizona. Is there something you're kind of investigating right now with research? I mean, just throw it over the top and make me feel a little less than right now, because I barely am able to feed the dogs at night when I get home.
Yeah, no, I mean, I may make myself sound like I'm more than I am. You're right. It is. I mean, I'm a clinical guy first. I'm a patient care guy. I've always have been. I don't do as much research as colleagues, but I have affiliated, and it's been a great relationship with Stanford over the last few years. One of my very good friends, Mark Safran, is the chief of sports medicine there, and they brought me on as an adjunct professor a couple of years ago, and I'm involved a little bit more with teaching residents and fellows. We have them involved with the A's now, and he's always said he feels that my contribution is as a clinical guy, because I mean he's published umpteen things, and I would have liked to do that more, but there are only so many hours in the day. Yeah,
I hear you.
And but I think it's important. I think it's beholden upon us to stay abreast of the research, and I think I just feel like at some point we have to do our best to give a little bit back to research that has given us so much in terms of our understanding. But yeah, it is hard. It's hard to do quality research for sure. You need time and resources.
And with the time that you have where you're actually looking at scientific journals and research studies, outcomes, and so on, is there anything right now that has kind of piqued your interest going, oh, that's cool, even if it's completely, finite in your world of orthopedic surgical procedures or whatever? Is there anything right now you're like, oh, that's kind of cool, I want to learn more about it?
Oh, well, there's so many things, but like I said, the hip is if I end up being a specialist someday when I get older, when I grow up, it'll probably be hip, because I'm a hip hip arthroscopy, hip replacement, but also the sports medicine part of hip. And I think just the whole spinal pelvic relationship, the flexibility around, there's so many angles. I think everything from the pop-up surfing. I mean, people that can't get up on a surfboard, can't get their leg through, I think a lot of times is their hip. But whether it's hip replacement or biomechanics in throwing, I think there are that's probably the area. I mean, I could get into specifics of the different things, but I think that's probably the coolest thing right now for me.
Yeah. No, I love it. I mean, one of the screenings that we do here at our facility is pelvic screening, closed chain, upright, loaded against gravity. How well do you anteriorly, posteriorly tilt? How well do you translate laterally? How well do you laterally tilt and rotate left and right? I mean, that in itself, if we just start there and do nothing else, that's going to give us a tremendous amount of insight in terms of the whole chain. And if something's off at your center, then that something is going to happen further out of the chain if that's not being created right from the origin of muscle contraction or joint motion, however you want to play it. But yeah, I love it. I totally geek with you on that.
Yeah, if you see, it's not a ton of guys that have had it, but there are quite a few guys in the big leagues have had hip arthroscopy surgery for impingement, and that's a fascinating area, because it can be a morphologic thing, meaning their hips are just shaped a certain way, or it can be a dynamic thing. And you had a couple guys, you can just see them, you look at them in the sagittal plane and their butt's sticking way out and their back's arched, that their socket is just clamping down on their head, and they have a dynamic impingement. And, if they're not treated right, that would be somebody that would end up going into surgery, and they may shave a little bit of that cup away to make more room. But what they really need is more flexibility around their spinal pelvic junction to get their pelvis in a better position. That's a great example right there.
Yeah, and we're talking about a rotary athlete who is completely creating force production or torsion primarily in one direction. So if we want to talk about joint mechanics, one hip is most likely going to be forcefully externally rotating while the other one's internally rotating. So, or extending while the other one's flexing, abducting while the other one's adducting. We look at all three planes of motion. So I guess one of my last questions to you is, knowing that, have you noticed a correlation between the hip that's having issue with the arm that is the throwing arm?
Oh, no question. Yeah, and I think, I won't say names, and I'm going to keep my fingers crossed, but one of our big leaguers I operated on this offseason, this hip, I saw him for the first time last spring training, and his hip didn't move. It wasn't painful, but, speaking of the preseason examination, you're going through and screening, and like, he had negative internal rotation. And then I saw some footage of him pitching, and he could not rotate through his backside. He was just lifting his foot off the rubber, and he said, "Yeah, it's just the way I've always been." And we ended up fixing him. He had basically had a big bony impingement, got rid of it. I just talked to him this morning. He's feeling better. He's finally put a pitching toe on his cleat, if you know what that is, because he can drag his foot. He can turn his hip in finally. That's very cool stuff.
That is cool. Now he's got to kind of organize all that power production that he has at his disposal. That's
it's interesting, yeah, because he's getting some soreness. He's getting some soreness in muscles that he's never has before. I think they've just been sitting there for 22 years waiting to be used, right?
Oh, man, that's awesome. Will, I have a feeling we could keep on going, but I don't want to take any more of your time. I've taken up 4 patient loads of time from you, and I really appreciate your willingness, your patience, your availability. This has been great. I will invite you to a surf session in Santa Cruz, but I know you're going to be packed all the way through the season. So let's hope that after the first or second week of November this season, you'll have some time available to kind of just come down the coast, or we can meet halfway and paddle out and enjoy some waves together.
Well, I noticed, I think your office is on 41st.
Yes, sir. Right down from the hook. Pleasure Point.
So I sneak down more than you think. I actually, I do things at sort of unorthodox time. So I chose to hit the hook right about kickoff on Super Bowl Sunday, for example.
That was a good day.
So, because I knew, I said, there won't be any traffic.
Nope.
And there probably won't be as many people out. Probably the crowd won't be as aggro.
And the waves were decent. They weren't great, but they were good.
It wasn't big, but it was clean. It was a beautiful day.
I'm surprised. I probably dropped in on you.
Maybe.
Well, we'll make that. I'll give you my cell, and then you can text me, and and I'll meet you out in the lineup for sure. This has been great. If people are interested, maybe they're in the Bay Area and they need a little advice, or maybe some arthroscopic kind of or orthopedic kind of consultations, can they go to your office, and how so?
Absolutely. So my office is in Walnut Creek, and I'm sure they could Google my name, or like I said, I have very friendly staff. They call, and Teresa or Terry or Michelle will answer the phone and get them in.
Beautiful. Well, I can't thank you enough for your time. This has been
thank you,
fantastic.
Rocky. This is awesome.
And that's a wrap for this week's episode of the Zealous Podcast. I want to thank Dr. Workman for coming on, as well as the Oakland A's organization allowing this to happen. Remember, you can go to Setanta College, 10% off your tuition if you enter RS10, setantacollege.com. They've got certifications and bachelor's degrees, not only master's degrees. So check them out. Online education at its finest, setantacollege.com. In the meantime, we'll see you next week.